Wala. Nataik ko lang ni ngawi. Nangunod sa hinggen ito.
Please mute yourself. All the participants are requested to mute yourself.
Hindi ko lang.
ऐसा हो रहा है, एक आदमी आगे बैठ के सुनाई बना रहा है, उसमें ऐसे करो।
Nandini ma'am, we can start with the session.
Sure.
A very good evening to our esteemed speakers, chairperson, and our valuable guests. I, Nandini Sharma, Assistant Professor in Clinical Psychology, Amity University, on behalf of Team IMHRC, welcome you all to the third lecture in the series of Masterclass in Mental Health, Reflections. Reflections, a monthly mental health lecture series, is an initiative by Indian Mental Health and Research Center, started with an ambition to disseminate knowledge to anyone and everyone keen to learn. This is an illuminating platform dedicated to foster a deeper understanding of mental health and well-being. This series brings together experts, professionals, and enthusiasts to engage in insightful conversations about the intricacies of mental health. The topic of discussion for today's lecture is eye movement desensitization and reprocessing therapy. And our esteemed speaker for today's session is Ms. Preeti Pandey. To briefly introduce, Ms. Preeti Pandey is an RCI licensed clinical psychologist with 8 years of experience in dealing with cases related to mental health issues. She completed her master's in applied psychology from Jamia Millia Islamia, New Delhi, and MPhil in clinical psychology from Central Institute of Psychiatry, Ranchi. Her past work profile includes assistant professor psychology in SGT University, Gurugram, clinical psychologist, District Hospital, Muzaffarnagar, Uttar Pradesh, and assistant professor clinical psychology, Amity University, Uttar Pradesh, Noida. Currently, she is working as an independent practitioner in Noida, Uttar Pradesh. Along with teaching, her work experience also includes conducting psychological assessments as well as psychotherapies for children and adults of all ages. While working with Government District Hospital, she also extended her services in community mental health program. She is a trauma-focused therapy and have been trained in eye movement desensitization and EMDR association. With this, I would further extend my invitation to Dr. Mustafa Nadeem Kirmani sir, who is preparing today's session. Dr. Kirmani is an associate professor in psychology and is currently in Amity University, Haryana. With an extensive professional and academic experience of around 8+ years, he is a PhD holder and had pursued his MPhil in clinical psychology from the prestigious National Institute of Mental Health and Neurosciences. His expertise includes psychotherapy and counseling with children, adolescents, adults, geriatric population, marital enrichment therapy, to name a few. He has many national and international publications under his name and also has been awarded in quite a many paper presentations. So with this, I extend my heartfelt welcome to our speaker and our chairperson.
Thank you, ma'am.
Before we begin with the session, I would want to inform our participants that the duration of session is 1 hour, including the lecture and the discussions. And I would request the participants, if they have any questions or any contributions, kindly write them down in the chat box, and we will be addressing them towards the end of the session. I would now hand over the platform to Ms. Preeti.
I hope I'm audible.
Yes, ma'am.
Yes, you are.
All right. Okay. So thank you for giving me this opportunity to talk about eye movement desensitization and reprocessing, a trauma-focused approach. Something I got to experience, I think, 3-4 years ago. I mean, during COVID time, my learning was about eye movement desensitization and reprocessing. And from there, my journey began. So let me talk about, how eye movement desensitization and reprocessing looks like. And maybe let's talk about EMDR through the history of EMDR. So Dr. Francine Shapiro is the person who discovered EMDR in 1987. And it's like a chance discovery. And it was, she says it was spring of year 1987. She was taking a walk, and at that time she was having some distressing thoughts. Suddenly she realized that those thoughts were no more distressing to her. Something had happened. And then she thought, let me see what has actually happened. So she found out that while she was thinking about those thoughts, she was moving her eyes, rapidly. Her eyes were in a certain position, and she was moving them rapidly. And then she realized, yes, this is how the desensitization of my anxiety has happened. And now she got more and more curious about it. She thought, let me try it with other people around me. And then she would ask them to think, and people around her, she would ask them to think about things that were distressing them. As they would think, she would ask them to go with those rapid eye movements. And same result, the content was no more distressing for them. And this is how she thought, let me create a proper protocol, because this particular way is helping me to release anxiety. And she created a protocol, and now she thought, let me use it with old memories of people, old memories which are distressing. And again, she would ask them to think of that old memory, and at the same time, she'll ask them to move their eyes. And wow, the distress was no more there. Now she also realized that there were many people who were not able to move their eyes. And because they were not able to move their eyes on their own, then she came with the idea of using fingers for eye movement. And she would just ask them to follow my fingers. And now she thought it is working well with normal population, population who have distress, but it is not extreme. Now she thought, let me do one more thing. Let me try to find a homogeneous group and use the same, homogeneous group of such people who have distressing memories as a reason for their current mental health issue. So she thought, who that population can be. And now it was war veterans, it was survivors of rape, any kind of molestation or assault. Out of everyone that she thought, let me use war veterans for my further work. She created a protocol, and then she started using the same protocol on war veterans, who were diagnosed with PTSD. Now what she would do, she would ask them to think of that distressing memory, to bring that memory to their awareness. As they would bring it to their awareness, she will go with the eye movement, and then she'll say, what are you noticing now? Okay, and then whatever they would notice. So there is set of eye movements. It's like, think about the memory, eye movements, then she'll say, what do you notice now? They'll say something. And then she will go with that. Then they will say something else. Then she will say, go with that. Subsequently, she realized that distress associated was with that memory was no more there. That memory was no more haunting for them. Instead of that haunting experience or image, there was an image which was more pleasant. And she realized that they were feeling more uh, powerful, more, hopeful than what they were feeling before she did EMDR work with them. And now, because the results were wonderful, she thought, let me try more. I mean, that her journey did not stop there. It still continues, okay? Like every single moment in the world of EMDR, new things are happening, new researches are happening. So now she introduced one more thing. So until this point, it was just EMDR. It was just desensitizing of anxiety. Simple behavioral response, part of behavioral approach. Now she started doing one more thing. She would ask them to think of that memory. And then when they would think of that memory, she will ask them, what negative belief do you have about yourself when you think of that memory? Okay. All right. So she would focus on the negative belief associated with that memory that is haunting them. And they will come with their belief. It could be, I am maybe not good enough, I am not safe, I am not powerful, I am not in, I can't trust myself. It can be anything. But they associated with that particular memory. Now she would ask her for one more question. Instead of that, uh, negative cognition, what cognition they would prefer to believe. So again, I am using my, a very layman language. Actual में there is a script, ठीक है? There is a script which one has to follow while they are using EMDR protocol. Right? It's like first memory, then the negative cognition, then they'll, instead of that negative cognition, what positive cognition would they want to have here? And now she will do the desensitization work. And she realized it is no more just about desensitizing the anxiety. No more only a behavioral protocol. It has included cognitive restructuring to it. So now it was no more EMD. It started at EMD, eye movement desensitization, but now she called it eye movement desensitization and reprocessing. Earlier, it followed a behavioral approach. Now it was an integrated informational processing approach. Okay, so this is how EMD started, like eye movement desensitization started, and how it got changed into eye movement desensitization and reprocessing. Now let's talk about the kind of model which EMDR uses. It is called adaptive information processing. In short, AIP model. So AIP model is the concept of psychological self-healing, a construct based on body's healing response to physical injury. Okay, it's self-healing response to physical injury. So imagine a normal situation. There is a homeostasis within me. There is a neural homeostasis within me. My adrenaline, amount of adrenaline, my cortisol response, my neurotransmitters, everything is more or less in balance. And when a situation happens, and I wasn't aroused to an extent or distressed to an extent that this balance was not disturbed, okay? Because that this balance was not disturbed, my brain was able to process that information properly. Imagine my brain as an information processing device. Because the homeostasis was not disturbed, I was able to process it properly and adaptive resolution happened. And because it happened, but everything that was positive. If it was a positive experience, wonderful. It was thoroughly processed and it went to my adaptive memory network. And if it was a negative experience, yet my brain was able to process it properly. It again went to my adaptive memory network. So right now, everything positive that I have within me, my self-worth, my learnings, my experiences, everything is a product. I mean, it's coming from my adaptive memory network. Imagine I ask you, think of a time in your life when you felt you were very courageous. Okay, suddenly a memory will pop up, and in that memory, through that memory, you will be able to connect with your courage. So where is it coming from? It is coming from that adaptive memory network. Now, there is one more network that is called maladaptive memory network. And what happens when there is a memory which my brain was not able to process? What happened because the situation was extremely arousing for my brain? My this homeostasis got disturbed. Arousal was so much that that proper information processing could not happen because it was not processed properly. Instead of going to my adaptive memory network, it went to my maladaptive memory network. And now, imagine 4 years ago, something happens with me, something where my body was, I mean, my information processing did not happen properly. And this memory was not, I mean, it went to my maladaptive memory network. Anytime something similar happens, a network is created which gets connected with my maladaptive memory network. And at the same time, it's a response like the past becomes present. You may have heard it from a lot of your clients. They say, the situation was not as big as I reacted to that. I do not know why I reacted that way. I have no idea. And the reason was the past became present. Everything that was stored in the similar memory network became present. He was not just reacting to the present moment. The person was also reacting to the past. That is why it was so big and so intense, so big and so elongated for them. All right. So again, adaptive memory network and maladaptive network. So now, any stimulus, I'm reading the third stanza here, I mean, third line here. Does any stimuli from the present can get connected to negative experience in the past, hence triggering a reaction. Okay. Now let's talk about components of memory. So again, you guys can think of any memory, maybe today morning you were doing some work, you were teaching in a class, you were being taught in a class. Think of that memory, and as you think of that memory, you will start getting images related to that memory, sounds, smells, taste. So this is a sensory input related to that particular memory. Thoughts, you will start getting thoughts related to that memory. Emotions, like how I felt then, you will be able to feel it now too. Body sensation, again, this is a very powerful mechanism, especially not mechanism, but it is a very powerful part of any trauma focused approach. It doesn't just stay till thoughts and emotion, it talks about body sensation too. How my body sensed it, what was the felt sense like. So again, a memory has a body sensation to it, and then beliefs. We all know what beliefs are. Okay. Talking about memory networks, I have already described what memory networks are. Adaptive memory network, where all my memories which were processed properly go. Okay? And everything that is like a positive experience to me now, a learning experience to me now, everything comes from this adaptive memory network. Maladaptive network, memory that one couldn't process then because the brain, I mean that information processing, the body was so aroused that one couldn't process it, goes to my maladaptive network. Now, anything similar that happens in my present gets connected with this maladaptive network. So now let's talk about bilateral dual attention stimulation. So I told you earlier, I mean, Francine Shapiro found out that when she was moving her eyes, and as a result of moving her eyes, the desensitization was happening. Okay. So now actually happens once we move our eyes. Okay? So it's called bilateral dual attention stimulation. It's a rhythmic alteration of stimulation between the left and our right brain. Okay. So again, we all know our right side of our brain is connected to left side of our body. Left side of our brain is connected to our right side of the body. And imagine if I'm doing this, what I'm stimulating the information. I'm getting the whole brain, left hemisphere as well as the right hemisphere. Left hemisphere, all the cognitions, all the thought level material is stored there. Everything that has to do with emotions is stored here. So when I'm doing it, okay, bilateral stimulation. I'm actually stimulating, I'm opening the information processing gates. And now it is just one mechanism. I mean, when you say follow my fingers, it is just one mechanism. Hello? It's just one mechanism. There are other ways also. The ground rule is I have to do bilateral stimulation. It can be butterfly heads. Okay, it's like one tap, two tap, two tap, two tap. It's again one more way to do bilateral stimulation. If I'm taking an online session, I cannot do it. I mean, wouldn't work as beautifully as an offline. It would work in an offline session. So I can go with these butterfly taps. Even there is one more way in which we ask the client to stick two post-its at two ends of my laptop and then to move my eyes. I mean, it's like there's one post-it at the left corner and then one at the right corner, and then I am asking the person to, imagine if it's like image and then move my eyes. Okay. And there are other stimulations also, like we can give them stimulation through sounds, through lights, anything that can be used in the form of a bilateral stimulation. Okay? Now, there is, so as I had told you earlier, in the history of EMDR, I spoke about initial part of EMDR when it was just being born. I mean, when it was just a toddler. Okay, I think just an infant. Gradually, more changes occurred. And the current protocol, which EMDR Association uses, has three prongs to it: past, present, and future. Okay, so past would mean that things that happened in the past. For example, okay, there is a person who is having a distress in present related to his relationship with his girlfriend, and he says that I need a lot of validation from my girlfriend. I have every time I'm always thinking what more to do to please her. Okay. I will ask her what's happening in the present moment, like what situations are happening, and can you think of experiences in the present scenario where like which speak about it, which talk about it. That person will be able to give me few memories from the present. Through these memories, I will try to trace back, okay, and go to his past to find out where the real problem lies. Where did it actually start? Okay. So maybe, we'll float back and we'll find out memories. So we have our own tools in EMDR, which we use to float back and find out memories from the past. And then, so these are memories for the past, part of our past prong. Present, things that are happening in the future, which is a cause of distress for the client, part of the present prong. So when we are doing an EMDR work, we find memories from the past one by one. We process those memories. Okay, we may start from the first memory of that client that comes to his consciousness, and then we will process it thoroughly. Then we will move to the next memory, third memory, fourth memory. And maybe when all the memories are well processed, we will move to the present part, things in the present which are disturbing him. Okay. And we will not just stop here. Once we have desensitized all those anxieties, all those haunting experiences, and made them normal for that person, we will hop into creating future templates, which means that uh, if something similar happens in the future, how am I going to respond? So we work on the past, then we work on the present triggers, and then we create future templates. Okay. Now, basic components of an EMDR process, as I told you, in its nascent state, it was very different. It was just about desensitizing the anxiety. Then it was finding the cognitions, but gradually things were added to it. So, what are the basic components? We asked them about the image of, but like we asked them to think of that memory. What image looks like the worst part? Then we talk about what negative cognitions do they have about themselves when they connect with. Then we talk about positive cognition. What would they prefer to believe about themselves? हो सकता है the person says that when I think of this memory, I feel that I am not safe. Positive, what would you prefer to believe about yourself? Maybe the person says, I'm safe now. Okay. Then we try to find out the validity of cognition, VOC, of this positive cognition. It is more like if it is a memory, when I'm thinking of the memory now, and the words I'm safe, how true they feel to me now on a scale from 1 to 7, where 1 is completely false and 7 is completely true. So the person has to, he may say, I just feel it like a 4. I just feel it like a 5. So we note it. Then we ask them to find out their emotions. So that when they play that memory in the present moment. So just be very clear about now, here and now, what emotion am I feeling? Here and now, when I play that memory in my mind, what negative cognitions do I feel? Okay. Because from that memory, what I feel now is remaining as a negative part. Maybe rest of it was already processed. And we have to process what remains in the present. That is why we always focus on what are you feeling now. Okay. And then we asked about how much distressing this memory is, which is found by using, which is we give ask them on a scale from 0 to 10, how much distressing this memory feels to you now. And then finally, where do you feel it in your body? As I told you, every memory has an associated body sensation. So the person may say, oh my God, I can feel heaviness in my chest. I can feel palpitations happening. I can feel my back is so stiff. So they will have their individual physical sensation associated with that maladaptive memory. Moving to the next part, that is cognitions. Cognition play an important role here. Okay. And EMDR experts have found out 4 kind of informational plateaus under which they classify their cognitions. One is responsibility. So in responsibility, the cognition would be like it's again defective. I am defective. I am bad. I am not good enough. I am not lovable. It's all about me that there is a defect that lies within it. Okay. When it says action, I did not do it properly. Then we may ask, what does it tell you about yourself? Okay. So it again about me, a defect that lies within me is associated with that memory. The second informational plateau is safety, vulnerability. In this kind of informational plateaus, cognitions would include I'm not safe, I am in danger, okay, something like that, which talks about that I am vulnerable, I am not safe, I am dangerous. So all similar cognitions will go in this information. Then comes power and control. Here, the person will feel, such cognitions will be a part of where I am not in my control. I am powerless, I am helpless, okay. Every single cognition which is associated with feeling that that particular thing is under not my control. Okay. And then connection and belongingness. So this is 4th cognition, which was added to these information process very late. Okay. And it is all about being connected, feeling belonged. So a person may feel, the cognition may come out as I'm alone. I am I'm left out. Okay. I don't belong. So and these kind of cognitions are usually seen in cases who have attachment injuries, relationship related issues. So they may say I am alone. Like, what do you, when you think about that image, what do you feel about yourself? What do you think about yourself? But I'm all alone. Okay, something like that. So these are the 4 informational plateaus under which we find our cognitions. Now let's talk about phases of EMDR. Okay, so it's not a simple protocol where we say ki, bring that memory, desensitize it. Okay, or bring your memory, what negative cognitions you have, and then do your eye movement. It's not as simple as that. They actually have phases too. And the present EMDR association follows 8-phase protocol where they take history, okay, then they do proper preparation, then they do assessment, desensitization, installation, body scan, and closure. Okay, so I'll talk about all these one by one. So, what happens in history? My client comes to me and I start taking history the way we take history in every single therapy session. I mean, kind of therapy. Okay? Through our history, we also try to figure out whether my person is fit for EMDR or not, because each and every person at any point of time is not fit for EMDR. Okay, so I will have to see whether my person, I mean, I can do EMDR now. Can I do EMDR after doing a good stabilization or a preparation work for a few days? How much should I wait before I start my real EMDR work? Imagine a person who is coming from extreme distress. Okay, the person is not even able to, I mean, when I'm talking to the person, I can clearly see that only 20% of that person is with me in session. I can't do any MDR with that person. It's like rest of him is somewhere else. So I have to create that stabilization first. Okay. So once I've taken my history, I have gathered all the data. I go to the second point, which is preparation. I prepare my client for EMDR work, which means, I mean, again, imagine right now, I mean, 4 years ago, something bad happened to me, as a result of which I am already traumatized. Okay. Now, without preparing that patient, I mean, that person in the present, in his present self, which would mean creating as many resources, strengthening him as much as I can in the present moment, so that when he goes back to the past memory, he doesn't feel overwhelmed. Okay. He is able to be there with that memory. It is distressing, but it is not going to re-traumatize it, that person. So this preparation phase is extremely important, where I am doing every single thing to prepare my client for my real EMDR work. Okay. In the history phase, I had done one more thing. I had found out all the pertinent memories. Remember, past, present triggers. Through our present triggers, we find all our past memories. So all that work has already been done. Now, when we reach the third stage, which is called assessment, we are picking one memory. Okay. And we are doing a thorough assessment of that memory, which would mean what image is disturbing you. When you think of that image, what negative cognition is there? What positive cognition would you prefer? What emotion are you feeling right now? And what's happening inside your body? So I am going to assess every single thing about it, along with the subjective unit of distress that which that person feels at that moment. Okay. Once this assessment has been done, we move to the fourth stage, which is called desensitization. So this is the stage where we desensitize it. Okay. And once we have desensitized that memory, I mean, I would ask that person, think of that memory and the words. Maybe the negative cognition for that person was, I am helpless. Okay. Think of the memory and the words helpless. What do you notice now? Maybe the person say, oh God, I don't notice anything. I feel all calm. I'm composed. I'm too relaxed. Maybe I think I'm powerful, feeling more powerful right now, which means our desensitization has happened. Once it has happened, we move to the next stage, that is called installation. That is the stage where we are installing that positivity, which he had thought at that time. I think I would prefer to believe that I am powerful. Okay, for if I'm powerless, I am powerful. Now, we in this installation phase, we will install this positive belief. Once we have installed this positive belief, as I told you, body plays a major role in any trauma focused work, including EMDR. We finally do a body scan. So what we ask them to do, keep in mind that memory and the words, I mean, I am powerful. Okay. Now, start scanning your body, start from the top of your head and gradually move towards the bottom. Okay? And any place you find any kind of troubling sensation, anything unusual, any discomfort, notice and then let me. Okay? So if with that memory and with that positive cognition, the body feels all relaxed, it means we have thoroughly processed that memory. It is not going to haunt that person ever. But if we have not been, I mean, if there is still some sensation remaining, maybe the client says, oh my God, I can still feel some amount of heaviness in my shoulders. It means still there is something that remains from that experience. Then we will desensitize that also. Once the person says, oh my God, now my body is all clear, it means it's the time to say that now we can close our session. Okay, the closure happens. Sometimes we are not able to process one memory in a single day. Okay, so when we are not able to process one memory in a single day, then it means that it is going to go to our next sessions too. Then there are different steps for closure. Okay, and when we know that, I mean, we have already processed it, then we close the session with, and we also tell them the processing that we have done today may happen after a session too. Okay, so you may have any new insights, any new dreams, behaviors, thoughts. Okay, jot them down, and we will talk about them in our next session. Don't forget to use your coping your coping skills if required, because sometimes between sessions still processing is happening. They may have some insights, some thoughts, some images which is more distressing. So they should always be ready with, I mean, they should always have their coping mechanism, I mean, coping skills kit ready with them so that they can work on that problem at that time, whatever. Okay? And now, once we have done all this, okay, so imagine in my today's session, I was able to uh, complete my, completely process this memory. Now, on my next session, when I meet my client, I am not going to start directly from my next memory. I am going to reevaluate the previous memory first. So it would be again like when you think of that memory, what's happening now? Okay. If that person say, oh my God, when I think of that memory, nothing happens. I feel all chill. I'm all cool. It means that it's good time for me to hop into my next memory. If it says still distress is there, then we will follow the old path to, get it to process everything that remains from that. So this is how 8 phases of EMDR look. Again, it is just an idea of how an EMDR therapy looks. There are so many protocols. There are so many scripts that are followed. I mean, proper script that one has to follow while they are doing. Okay. So moving to, again, my next point, which is EMDR response to other psychopathologies. So again, as I told you earlier, PTSD was first illness that it tried to treat. And what was the reason behind? Because PTSD has memories, distressing memories. And once we are able to process those distressing memories, we are able to come out of that zone, okay? That distressing zone. Somehow, gradually, Shapiro and other people working in this area found that any illness for which the reason was a distressing experience, okay, can be handled very well with the help of EMDR. So it can be used with depression. It can be used with any kind of other anxiety disorders. It has wonderfully been used with phobic disorders, dissociative disorders, even personality disorders. Only thing is, as extreme the illness, I mean, as much extreme that illness becomes, one has to be more and more aware of different protocols in EMDR, because a simple protocol will not be able to handle a case of dissociative disorder. So one has to have all the tools ready to work with a patient with a certain type of experience. Again, single trauma is easier to process, but if it becomes complex trauma, okay, then it is a more complicated process, because so many, I mean, it's not, again, if you talk about cognition, it is not just about when I think of that memory, I feel helpless. It will be, I feel helpless, then there will be one more memory network associated which says that I'm alone, then there will be one more network, I'm unlovable. So imagine it's like so many cognitions coming together and creating this structure inside that person. I mean, this chaos inside that person. So then one has to be ready with more and more tools. And there are, I mean, there are basic level trainings in EMDR, then there are advanced trainings in EMDR, then those advanced trainings are about particular disorders. Okay. So again, it's like EMDR today is being used in number of mental health concerns. Okay. So yes, these are the references that I have used for my today's presentation. And I think it is a good time for me to stop here and welcome your questions.
Thank you so much, ma'am. Before we proceed towards the discussion and the question answers, I would request our esteemed chairperson, Dr. Kirmani sir, to reflect upon the topic and share his valuable thoughts with us.
Okay, thank you. Am I audible?
Yes, sir.
Okay. First, I would like to thank you for giving me the opportunity to chair the session. So, whatever I would like to say is therapy is basically as a process, a very professional process. As Preeti Pandey was presenting, Madam was presenting on EMDR, it means that basic therapy skills we can acquire in a professional programs like MPhil, PDCP. But for specialized therapies like EMDR, like play therapy, like other therapies, we need some training. So that is very, very important. So it is basically an eclectic approach therapy. EMDR has to be used along with other components of therapy. So one lesson for all of us is we need to have some brief training in specialized therapies like EMDR before we start practicing. I'm saying this that we have to do first training program, basic training program of therapy like MPhil. Then we need to specialize ourselves in different therapies like EMDR. Number one. Number two, it is very important technique. I'm not an expert in that, but I'm saying based on my experience and based my knowledge that it has very important use in trauma-related conditions. Okay, and to be very frank, I know about it, but if you ask me that you do it practically on clients, it will be difficult for me because I'm not well versed in terms of a skill-based aspect of it. Theoretically, conceptually, I know. But based on the theoretical models, it is very, very important. This is a second point. And third thing which is coming to my mind is we need to sensitize our professionals, ourselves, our trainees, that we need to brush up first clinical skills. Basic clinical skills should be very strong. Based upon that, we can build up those, higher level skills or macro skills or, specialized skills, what is a better term. So that is also very important. And we need to grow. We need to just upskilling ourselves by moving into different directions, by learning different type of therapy, different sort of psychodiagnostics also. So that is what I was thinking. And I'm now reflecting that I also need some sort of a basic training and skill-based things so that we can also use it for our patients. So these were the things that came into my mind. Thank you. Thank you, ma'am. Thanks, Preeti Pandey, ma'am.
Thank you, sir.
Thank you so much, sir. Thank you so much, ma'am. In lines with what sir has said, I have one question. I think that will be helpful for all the participants. What is the basic training needed in EMDR to practice it as a part of therapy? And once an individual is equipped with the training, do we need any further training, or does the person need to update themselves from time to time? And in the practical application also, how much practice does the person need to understand that yes, I am in a position to use it as a therapeutic technique with my clients or my patients?
Right. It's a wonderful question. Wonderful. So, in India, we have an association called EMDR Association. So, its headquarters are in Mumbai, and it is a part of the bigger EMDR Institute. And it has two type of training courses. One is basic level EMDR and then advanced EMDR. Okay, and it's like it's spread over a week, and so they give you proper trainings in that training environment. And instead, they teach at the same time they conduct skill-based training. I mean, uh, they will ask you to do it. They will supervise it. One, okay, and they do not leave you there. They will have 5 consultation sessions after every month. After this training is over, like basic EMDR, 5 consultation sessions. Every consultation session is well supervised. There are a number of consultations who give their ideas. We submit our cases. They give our feedbacks on that. Okay. So once you have submitted, I mean, you have become a part of that consultation team, then you have submitted your cases. They will certify you that you have completed basic level EMDR. Now, after a few months, they will invite you to join their advanced training. If you want, you can join it. Again, the same thing happens. In this advanced training, we learn how to deal with complex trauma. It was about simple trauma. Now it is about complex trauma. And again, skill-based learning. After that, it will be consultation. You will be given wonderful feedbacks. And once you submit your cases, you will be given the certificate to practice EMDR properly. Yeah. Okay. So this is how it goes. At the same time, I can say in the present work, learning never ends. Never ends. It's like I'm working with a person today, and I'm feeling, oh, now I know a lot about EMDR. I can work with a person, and then wow, something new happens. Something different occurs, and I do not know now what to do. I have to read more. I have to train myself more and more. And again, depending on the kind of psychopathology I'm working with, as complex as it gets, I have to be having a lot of tools to deal with that psychopathology. I hope I was able to answer this question.
Absolutely, ma'am. I think you have step by step shared how to get the training and then how to brush up and revise that knowledge. And this was also one of the questions by the participant, that where can I start to get basic training in EMDR? I think that has already been answered. So
It's like right now I'm doing one more course on EMDR, which is called Attachment Focused EMDR, and it is by Dr. Pandey. So it's an online course which is conducted in UK. So because again, when there are attachment injuries, what to do next?
So, like you already said, that learning is an ongoing process and there's no end to doing courses. So, yes, we do have to keep brushing up our knowledge and gaining new insights in the topic. Moving to the next question, are there any contraindications for EMDR?
So yes, there are a few contraindications, but I'll try to keep it very simple. Okay, when you feel that your person is stable enough to go back and work on those memories, which were the reasons for his present state, use EMDR. Whatever your person is going through. But if you feel the person is not stabilized, don't use EMDR on it. I mean, you can use EMDR on a case of borderline personality disorder. You know how much emotionally dysregulated a person with borderline personality disorder is. But the day you realize that now that person is able to tolerate that distress, is not dissociating enough. I mean, is not dissociating, okay? Is the time when you can give EMDR a try. So contraindications only and only when you feel your person is not ready for EMDR. Because again, I'm going back to memories, I may re-traumatize my person.
Thank you so much, ma'am. Now, the next question is that if a client feels distressed between the sessions while following the 8 phases of EMDR, do we stop the session or do we continue with it?
Again, it depends. So if again, I may feel that my patient, it's like I am processing a memory, it is going to be distressing. Okay. But until and unless my person says that, oh my God, I just can't take it. So there's a signal, show me your hand if you want me to stop. So this is something we already have told them. Okay. So if they show me their hands and say, "Ki bhai, stop," I am going to stop then and there, and I'm going to do some stabilizing activity. Okay. I'm not going to send him back with that same distressing state. I'm going to bring him back to the present moment where he is more in touch with the present. All right. Again, when the person says stop, when I am thinking, I'm saying, oh my God, so much distress is going on inside that person. I'm not going to say stop there. Okay. Because the person knows he can take care of himself. All right. Stabilization with any kind of trauma therapy. Whenever you feel my client is getting destabilized, stabilize.
I think that's a great insight to it. Thank you so much. We have two more questions asked here. One is that whether we can use it with eating disorder clients.
Oh, it has been like people are using it with eating disorders. I was reading case studies where they have used it with a case like epilepsy where brain is involved.
I am inquisitive along with it. Can we use it with adult ADHD?
See, the point is ADHD can use it, but think, if I'm thinking that I'm going to change those neuronal networks, which is a neurodevelopmental issue, then it is not going to help me. But because of ADHD, the person had suffered. I mean, he had to go through number of bullying experiences. As a result of his bullying experiences today, he feels that I am not good enough, or he feels I am powerless. And his current condition, his current psychopathology revolves around it. Yes, I can use EMDR there. But again, it won't be of any help if I'm thinking that I'm going to improve his attention or hyperactivity, something that is a neurodevelopmental issue.
All right. So that means we can use it for the associated conditions or comorbidities, but not address ADHD directly in that case.
Yeah, so the point lies, it's like, let's not talk about ADHD, let's talk about autism, which has its roots in, my neurology. Okay. Will I be able to change my neurology? If it's happening because of certain deficit in certain part of my brain, no, I won't be able to do it. But because of my autism, I had such experiences which led to my current depression, or I had certain experiences which led to maybe my current eating disorder. And if I feel my candidate is able to go through the process of EMDR, I will use.
Thank you so much, ma'am. The last question is if you can share any case study or a real cases that you have handled.
Okay. So this case I can never forget. So this person of mine, she was around 34, 35, married with 2 kids. And when she came to me, it was depressions. And the reason was someone very close to her stopped talking to her. Okay. And as a result of it, she was not able to focus on any single thing that should have been her focus. Okay. And then the guilt, I'm not able to take care of my children, I'm not able to take care of my home, I'm just thinking about this. So I asked, what's happening? Again, recent experiences. She spoke about few recent experiences. Through our recent experiences, we did a float back. We went to her past and found out what were the experiences in her childhood which made her feel this way. And experiences like many daughters in our country, or maybe in Asian world, many daughters are born with a feeling that I'm an unwanted kid, I'm a burden. Okay. The same cognition was the reason. So since I feel I'm unwanted, I have to do every single thing on earth to please people. And if I'm doing so much and still people are not happy, and if they're still not talking to me, it means again hitting that cognition that I am unwanted. Imagine this person whole life was about pleasing others. She would say, Preeti, if someone is being good to me, if I have a golden ring, if I'm wearing a golden ring, I can give it to her. Imagine the amount of people pleasing behavior she was indulging in, form responses she was indulging in. And I used this process of EMDR, and it took around an year to work with, because it's again something as complex trauma. Okay. Uh, you know, I mean, when we were towards the end of our therapy process, one day she says, "You know what, Preeti? Who says I'm unwanted? I know I'm super wanted. Whoever wants to talk to me should come and talk to me. If they don't want to talk to me, who gives it a damn?" Imagine someone who comes with an idea that I'm unwanted, trying every single thing on earth for their response, says this. This is, this is one of the powerful work that I did.
All right. Again, thank you so much, ma'am. We have just one more question with this, which has just popped in right now. Does this technique related with the psychodynamic aspects along with behaviorism?
So
Then-
it says that, yeah.
Ma'am, that's the question. If you're digging into the past experiences, is it also related to the psychodynamic perspective?
So it says that it takes a few components with, different therapies, but it is not exactly psychodynamic in nature. It may take few points from it, like again in psychodynamic, we go back in past, we dig into it, but the ways we do it is different there, and how we work on the memories is very different. So it has parts of behavioral therapy. It has part of uh, cognitive therapy. So many things are happening at the same time, but not one therapy in general.
All right. Thank you so much, ma'am. With this, we come towards the end of the question answers. Before we proceed towards concluding the session, I would request Dr. Kirmani if he wants to give a concluding remark.
Yeah, thank you. Actually, I was reflecting and thinking that please, we all need to remember that we have to do the basic training in clinical psychology, like MPhil and PDCP or XYZ, before then we can only do the specialized therapies. Just doing a therapy or certified therapy in EMDR or family therapy without MPhil or PDCP does not work. I think this message should go into deep of the of most of the people in the country. It should go to everyone. Number one. Number two, it's my request that I was seeing that someone was asking the PPT. I think the PPT is a hard work of the presenter or anyone who's presenting. What best thing is anyone can send the references rather than sharing the PPT, because it is the intellectual property right of the author or the presenter. I think we should give due respect to the presenter and don't ask for the PPT, rather ask for references. Thank you.
Thank you so much, sir. And on behalf of Team IMHRC, I would extend a big congratulations, a heartfelt congratulations to Ms. Preeti Pandey for delivering such a beautiful lecture. She has not only shed great light on how from simple desensitization of anxiety, it translated to EMD and then to EMDR. She has also elaborated in detailed lengths, covering history, goals, techniques, and 8 phases of EMDR, along with practical demonstration of some of the techniques with step-by-step application in psychotherapeutic techniques in the psychotherapeutic sessions. So I think it was such an engrossing session that we did not even realize how this 1 hour passed by. And thank you so much, ma'am. And thank you so much to Dr. Kirmani for sparing his valuable time for us and chairing the session. We hope for future associations with both of you. And since we'll be coming with a lot of lectures in the future also. And to the participants also, I would want to extend a great thanks. Though the vote of thanks will be now delivered by Dr. Sajid Kazmi, I still ended up thanking everyone on behalf of IMHRC. I would also want to tell the participants one last piece of information that the lecture will be available on YouTube channel of IMHRC. So anyone can go back and revisit and revise all the concepts discussed in this session as well as the previous sessions. So thank you so much. I would now hand over the platform to Syed Sajid Kazmi for a vote of thanks.
Thank you, Nandini ma'am, although you have made my work easier here. Anyways, just for the sake of putting up the things on record, I hope I'm audible.
Yes, sir.
Yes. First of all, thank you to the speaker, our learned speaker, Preeti ma'am. She took up time because we know that this is Saturday, and for private practitioners, it is a quite hectic schedule for them. So, but still, she obliged us, and she is here with us, and her hard work is very evident here. The kind of hard work, the kind of practice she is doing with the patients, and the kind of work. So we should all learn from it, and we are thankful to ma'am that she shared a piece of information. Or of course, it is just a piece because it is a detailed work, psychotherapeutic work. So, and it cannot be summarized in few hours. So it is just an overview. We can say that overview and summarization of what EMDR is about. Thank you, ma'am, for being with us here, and thank you for Dr. Kirmani sir for chairing the session, and your support and your leadership is always looked upon, and we always try
Thank you,
to
sir.
get and interact with you and get certain advices, and we will try to incorporate certain changes which you have over telephonic conversation also. We remember that, and we will be taking up into consideration. One thing very particularly, sir, highlighted, and we all should, with the young practitioners especially, we should always keep note to it that there is a proper channel of training, and there is proper ethical guidelines for training and practicing in clinical services, not only in India but throughout the globe. So wherever in whatever country you are practicing, first go by the norms. So whatever specialized programs are there, academic programs, teaching programs are there, we should get hands-on training and academic qualification. Then only we should go towards the micro specialization, so that we are first of all licensed and academically qualified to practice in that particular domain, and then we can delve into the finer details of any kind of psychotherapeutic practices, as sir was talking about. And the last thing which also sir pointed to it, and Nandini ma'am talked about it, that this whole idea of creating this lecture series is to put up certain quality of resources at single platform. So that is why we are recording all the sessions and putting it up in the open platform, that is the YouTube, so that whosoever is required to learn about these techniques, these topics, they can just browse it and they can get it just by a single click of the mouse. So all the lectures are freely available. There is no registration fee, no nothing, no cost hidden. You can just browse it and take note and learn the basic concepts. Stay connected. Each month we will be coming up with different topics, with different speakers, different chairpersons, with different set of knowledge and experience. Thank you very much for listening.
Thank you, sir.
Now
Good
we
night.
can end the session.
Thanks a
Thank
lot.
you, sir. Good night.